Hi, welcome to Dentology Code. Let's start our today's section. Our first question for today is structures very close to PDL. Cementum and alveolar bone and dentin, cementum and enamel, none of the above. So let's check the answer. The answer is A, cementum and alveolar bone. So alright, let's break down why A is the absolute perfect answer here. Think of the periodontal ligament as the ultimate safety net for your teeth. It's this incredibly smart fibrous tissue that fills the tiny gap between your tooth root and your jaw. Now on one side it attaches directly to the cementum, which is that hard outer layer protecting the root. On the very other side it anchors right into the alveolar bone, which forms the socket holding everything in place. So the PDL literally bridges them together, acting like a built-in shock absorber. So moving on to our next question. Patient had met with a blow to the jaw. On opening the mouth, the mandible deviated to the left side. This is associated with A. Left condyle fracture, right condyle fracture, alveolar fracture, or none of the above. So the answer is A. Left condyle fracture. So here's the deal with this one. When someone takes a blow to the jaw and their mandible deviates to the left upon opening, it's a classic sign of a left condyle fracture. Think of the lateral pterygoid muscle as the engines that push the jaw forward and open. Normally both sides push equally, but if the left condyle is fractured, that left muscle loses its function and stops pushing. Meanwhile, the healthy right side keeps doing its job perfectly, pushing the jaw forward and swinging it right over to the weak injured left side. So the jaw always deviates towards the side of the injury. So let's move on to our next question. Serial extraction is done to provide space for eruption of permanent molar, eruption of permanent mandibular canine and first premolar, eruption of permanent premolars and molars, eruption of mandibular incisors. So the answer is B. Eruption of permanent mandibular canine and first premolar. Alright, let's talk about serial extraction. Think of it as a strategic game of musical chairs for a crowded mouth. We use this guided procedure when there is not just enough room in the jaw for all the incoming adult teeth. By carefully extracting specific baby teeth in a timed sequence, we create a clear runway. Ultimately, the grand prize of all this planning is making perfect space for the permanent mandibular canine and the first premolar to erupt smoothly into their proper positions. It completely prevents severe crowding later on. So the answer is eruption of permanent mandibular canine and first premolar. Moving on to our next question. After uneventful extraction, hemostasis was achieved. The patient came back after 4 hours with bleeding that couldn't be stopped by local pressure. Your treatment includes application of ice pack, tight closure with suture, complete blood count and INR, cold compression. So the answer here is C. Complete blood count and INR. So when a patient has initial hemostasis after a smooth extraction but returns 4 hours later bleeding heavily and local pressure isn't doing a thing to stop it, we have a major red flag for a systemic issue. We aren't looking at a simple local tear here. So throwing an ice pack or a quick suture at it won't solve the underlying problem. Instead, we immediately jump to order a complete blood count and INR. We need to check their platelet levels and clotting factors right away to rule out an undiagnosed bleeding disorder or a medication issue. So let's move on to our next question. Which of the following tray are used for impression of a prepared tooth and bite registration of opposite arch tooth? A. Stock tray, B. Custom tray, C. Bite registration, D. triple impression tray. So the answer here is D, triple impression tray. So here is why D, the triple impression tray, is the ultimate efficiency champion in dentistry. Imagine saving a ton of time by capturing 3 critical pieces of information all at once. That's exactly what this dual arch tray does. When the patient bites down on it, it simultaneously takes an impression of your prepared tooth, captures the opposing arch tooth, and records their natural bite registration in one single step. It completely streamlines the workflow, saves materials, and makes things way more comfortable for the patient. So our next question is, for moving maxillary primary molar, first direction of force: palatally, buccally, occlusally, mesiodistally. So for removing maxillary primary molar, the first direction of force is given in which direction? That's the question. So let's check the answer. It's A, palatally. So let's talk about removing a maxillary primary molar. The secret to a smooth extraction here is starting with palatally. Now I know with adult upper molars, we usually go buccal first because that outer bone is thin. But primary teeth play by totally different rules. The roots of primary maxillary molars are widely flared, and right beneath them sits the developing permanent premolar. If you push buccally first, you risk fracturing those delicate flared roots or disturbing the precious permanent tooth bud. Moving palatally first safely expands the socket where there is plenty of clearance. So moving on to next question. A 5-year-old child came with his mother complaining of thumb sucking. He developed a 5 mm overjet and a 3 mm overbite. After 6 months, the child presented with a 3.5 mm overjet and a 1 mm overbite. The mother states that the child stopped sucking his thumb except when he goes to sleep. What is the most probable management? Refer to speech therapist, refer to thumb sucking habit breaking therapist, refer to orthodontist, follow up after 3 months and ask parents to let the child stop the habit. So our answer is D, follow up after 3 months and ask parents to let the child stop the habit. So let's check this out. Here's why D is the absolute smartest move for this 5-year-old. Look at the numbers. In just 6 months, his overjet dropped from a massive 5 mm down to 3.5 mm and his overbite improved beautifully. This means the moment he cut back on the thumb sucking, his jaw and teeth started correcting themselves naturally. Since he is only 5 and these self-correcting trends are already happening, we don't need aggressive therapy or orthodontic set. We just need to give him a little more time, follow up in 3 months and keep encouraging him to quit completely. So our next question. In deep cavities, if you want to avoid pulp exposure, which instrument you will use during caries removal? Gingival marginal trimmer, spoon excavator, slow speed bar, none of the above. So the answer is B, spoon excavator. Okay, here's the lowdown on deep cavity work. When you are that close to the pulp and want to avoid an exposure, the spoon excavator is your safest bet. Think of it this way. Rotary instruments like a slow speed bow are high powered, which can make it tough to distinguish perfectly soft, decayed dentin from sound, harder dentin right against the pulp. You can quickly drill too far, and this spoon excavator gives you excellent tactile feedback. You can literally feel exactly where the softer, decayed structure ends, allowing you to carefully scrape it away without breaching that vital, thin remaining layer protecting the pulp. Moving on to next. The patient has pain on chewing on a tooth after having a post and go. The X-ray is normal. What might be the cause? Vertical root fracture, loose crown, premature contact. horizontal root fracture. So the answer here is A, vertical root fracture. Alright, let's unpack this clinical mystery. When a patient has sharp pain only when chewing on a tooth after a post-and-core placement, even though the X-ray looks completely normal, your prime suspect is vertical root fracture. Here's why. Wedging forces from placing or loading a post can easily stress the root tendon, causing a microscopic vertical split. Because the fracture line runs parallel to the X-ray beam, it's notorious for being completely invisible on early radiographs. The pain happens because chewing flexes that fracture line, irritating the periodontal ligament. It's a classic hidden culprit. So here, vertical root fracture is the answer. So moving on to our last question for today. What is the most objective clinical indication of inflammation? Gingival color, gingival consistency, gingival bleeding, or gingival stippling? The answer here is C, gingival bleeding. So let's be real here. Looking at color, consistency, or whether a patient has nice stippling can be super subjective. And honestly, those features vary widely from person to person. But gingival bleeding, that is your absolute gold standard for an objective clinical sign. When you gently run a periodontal probe along that sulcus and it bleeds, the tissue is telling you a definitive, undeniable story of active microvascular breakdown and inflammation. It completely removes the guesswork, giving you a hard, measurable yes or no right there with the check. So that's it for today, guys. Keep revising these questions. Thank you.